bud. Welcome to a special bonus episode of ABA Inside Track. We're back home in Massachusetts after a great trip out to St. Louis, St. Charles for the Thompson Center's 20th conference. We're very excited to be invited back. We did a great talk. Well, we did a talk. I'll let you decide if it was great, on neurodiversity and setting goals in allyship with neurodiverse clients. And we will potentially be releasing that later in the future, though we did want to focus in this bonus episode on one of kind of the unsung heroes of the conference, which is the poster session that happens at the end of the first day. You can listen to our preview for October to hear us talking about some of the great talks and panels and discussions that we heard, but this episode is really just to celebrate a lot of the work that the students or postdoc students are working on. The Thompson Center conference is really great because it does have these three tracks. It is a medical, educational, and behavior analysis track. And I usually bounce between the education and behavior analysis track. Diana and Jackie usually do the behavior analysis track almost exclusively. But we almost never do the medical track because we are not doctors. And I think the posters are a really great place to see some work that is a little bit more interdisciplinary than many folks who are consuming ABA research are accustomed to seeing. And this year was really nice. We had a lot of talks about kind of some neuroscience, some medical models, so things a little bit beyond what we typically discuss. So we always have a lot of fun talking with folks who are presenting their posters. We hope you enjoy hearing just a sample of the poster sessions and the presenters in their own words. Please enjoy this sampling of the 2025 Thompson Center poster session. All right, talking with Farrell Landwehr about her poster at the Thompson Center. This is comprehensive follow-up care after NICU discharge. Sounds very medical.
Yes, so basically our project is kind of an observational and kind of first steps to a quality improvement project. We are trying to highlight, who should be followed up with at the NICU clinic, why different risk factors for why those aren't returning to the NICU clinic, what happens there and why it is of value to the patient and the patient's family. And then we talked to neonatologists at the university hospital and got their suggestions for what might make this better. So from January 2023 to December 2024, the no-show rate was 23%, which is very high, and it's typically high across the country. NICU follow-up rates are very high. So we did a literature review just to see who typically is more likely to return, those who are not likely to return. And so younger maternal age, maternal smoking or drug use, and then limited awareness of disease severity is a really important one. Also complex social determinants of health. So like food security, housing security, those all play into whether kind of the risk factors for those who might not show up to their clinics. What we're trying to do is get the NICU follow-up clinics to be more comprehensive so that the families can just follow up and have all their needs met in one visit. So they'd see PT, OT, geneticists, the developmental behavioral pediatricians, things of that nature. And so a lot of the neonatologists suggested that, and I know they've started to implement this at MU, is just like before the families leave the NICU, sit down with them, make sure they have the patient portal, they know how to access it, everything like that.
Sure.
We're trying to move towards getting like care coordinators, so that way we can like incorporate everybody together, kind of get a system going to help these families and to move as a cohesive group. And then better patient education about why their loved one needs to be seen more often or not.
When you're talking about sort of like more of that, almost like a package of let's get it all done in one visit to just make it less time consuming on the family.
Yes.
Do they have any suggestions, or are you thinking, is this sort of like, let's go from room to room and meet with everybody, or more like a round table, let's all get together with a focus on, hey, you and your family are valuable, and here's what we're all suggesting?
Yes.
Where would you, okay.
It would be more of like kind of the round table, kind of like we're all in this together, community, so that PT and OT and like nutrition, everybody knows what the others are specialists are recommending, excuse me, and just so we can all answer the family's questions at that time and that everyone's on the same kind of path. Just kind of to streamline the care and not make it as confusing for these families, because all these visits and everything can get like a little bit can be over the patient's or the parents' heads, and it's just very overwhelming.
It's a challenging. Anything to make going to the doctor for important things easy, low friction for families.
Yes,
I
absolutely.
endorse that. That sounds great.
Absolutely.
Well, Farrell, thank you so much for your time. Really appreciate it.
Thank you.
Ellie Random, thank you. So, development of a caregiver-informed inpatient behavior care plan for use in inpatient healthcare settings. Those great poster titles.
My poster is focused on the development of a caregiver-informed inpatient behavior care plan. So looking at how we support kids that have behavioral concerns when they're inpatient for a medical concern. We know that a lot of our nurses identify that they're not comfortable taking care of kids with behavioral concerns. They haven't received training on it. They don't feel safe. They don't know how to keep the child safe. So we're trying to find ways to sort of distill information that will be useful for taking care of that child safely. And the way that we're doing that is through a caregiver survey. So caregivers provide us with information about how their child communicates, what their behavioral concerns are, what might trigger those behaviors, and what kind of coping mechanisms might help support them in the hospital. And we put that into a one-page behavior care plan that is meant to be simple and actionable for our bedside nurses and therapists and techs and those types of people. And right now we're in the process of building these care plans and seeking feedback from our inpatient staff so that we can further refine them and make them more useful for our patients and for our nursing staff.
Oh, okay. All right. So got the sample one here, which no one listening is able to see. But how did you sort of just come about with it? These are the key areas? Just feedback from the nurses about the areas they wanted the most, or folks going to the hospital? Like, how did that come about?
So a combination of things. So both drawing from our nurses' experiences, what kinds of issues they were running into, what information they thought would be more useful, talking to families with children with autism, especially ones that have frequent contact with the hospital, and what types of things they're running into, what concerns they're having while in the hospital, and sort of combining all of those things to refine it.
Oh, great. So this would be, have you, it's been in use, or you piloted it a few times, or you're going to that stage next?
Yes, not yet, yeah.
Okay.
Ultimately, we would love to see these in the child's chart so they're available and ready to go if they show up in the ER, so that the staff know how to care for them and what concerns might exist for them.
Okay. I do love how I communicate and how to communicate with. So I like that, patient focused rather than, very patient-y neutral language. That was good. I don't know if that was your idea or one of the team, but that's good thinking. I love that for being person focused. So do you have hospitals that are maybe going to give this a try?
Yeah, so we're working with the University of Missouri in Columbia.
Okay. Oh, it's always when you interview university, there's usually somebody who needs to learn to use that. Right?
Yes.
Thank you. Appreciate you taking the time to talk to me.
Thank you.
So I am talking with Siri Arvello Pio about investigating the experiences of autistic students and families during the transition from high school to adulthood, which if you have the answers to that question, there's tons of families out there who will appreciate it. I'd love to hear about it.
Okay. Hello, my name is Hatsiri, and I am from Washington State University in Pullman, Washington. And I am working on this project with Dr. Holly Wittenberg from the College of Education down there. So a lot of my research right now doesn't have any findings, but we will hopefully get those soon, coming in the next future months. On top of that, my research, I like to say that it's really unique because it's not article-based, and a lot of it's lived experience-based. So that's something that I think I really like to point out a lot. When I was looking for articles, I didn't really find much about that gap of transition, and especially with low-income families, as we can see that we already struggle with financial problems, being able to access those resources, our parents, caregivers not being educated on these topics. On top of that, I've seen it firsthand with my aunt, and that was really hard to watch. With that being said, we're going to jump into our research questions. And I have 4 research questions that focus on the challenges low-income families face, what support resources made the biggest difference, and what barriers faced by low-income families trying to access services for the child diagnosed with autism spectrum disorder. And then how can we help the families plan that transition for their student. And I'm going to be using Bronfenbrenner's ecological systems theory just because it's a really unique theory that's like the environment that the student is. It can affect them either negatively or positively. It just really depends. And one thing I like to point out is the ecosystem. With everything going on right now with the world, we can see that funding is getting cut by education, and it's not directly impacting the student, but it's impacting the school program that gives those services to the special education, that then is going to make them stop those services and stop the student from receiving them, which then affects them directly.
Sure.
And then we have our inclusive and supportive practices that promote employment engagement for individuals with autism. So just different things that employment agencies can look into, and how we can make sure that our transition programs help them and make sure that our students know those independent life skills. Then I have my participants. I'm going to do 10 to 15 participants. They have to have a diagnosis of autism. They do have to have an individualized education plan or to verify, or they have to have a diagnosis just to make sure that they meet that. And then they have to have finished high school in the last 3 to 5 years. They have to participate verbally in an interview. And I don't have from non-severe to severe, just because I don't want to be that 1% that adds to them being dismissed once again. So as long as they can participate verbally, I'm going to go ahead and take them in. And then they have to be a member of a marginalized community and be a member of a household that receives school or public benefits. I don't have a definition for marginalized communities. I'm working with any population. As long as you fit into that criteria, I'm going to go ahead and take you in.
So self-identified. If there's a sense, or they're mentioning like, oh, I feel like I'm not part of the majority or something, that would
Yes.
count them in. Okay.
Yes. And then I'll be using snowball sampling, and I'll be recruiting them from Washington transition programs, advocacy groups, and college-based programs. And I will also be collaborating with the Disability Action Center down in Moscow, Idaho. That's going to be helping me participate, and I will also be doing emails, social media, flyers. I will be going around traveling to make sure that I'm getting those participants.
Sure.
And then I'll be doing interviews. Each parent and student's going to have their own, and these are going to be done via Zoom, Teams, or in person. And then I will be putting out the transcripts, removing any identifying information. And then I will develop a code book and use inductive coding in the first round to see what kind of patterns I'm seeing. Second round of coding, I will identify the themes that I'm seeing more and I really want to take for my findings. And then I want to enhance trustworthiness in my findings by doing member checks. So I'm going to be sending it back to the participants so that they can double check and make sure everything's good.
Oh, so they're included from the beginning to the end. It's their experience. Am I getting it right?
Yes.
Am I understand what you're hearing?
You're
All right.
You're getting it correct. Again.
So great.
Yeah.
Okay. So when you're done, the goal is going to be to have kind of this thematic analysis. These are common themes in the transition experience, things that went well, things that didn't go well, areas of support that did better than I expected, worse than I expected, didn't exist at all, and I wish they did. That's going to be very helpful information to kind of continue planning that transition period, which is just so challenging.
Yes.
So, but you haven't done the interview, so I'd say so. Like, what are your thoughts on? But you haven't done the interview, so I guess we'll have to wait to do the thoughts till poster 2 or publication that comes out of this. I'm guessing.
Yes, there's a lot gonna come out of this. Again, they're gonna be involved within this whole entire thing with our member checks, and I'm gonna keep updating them. And there's actually a form that I have for them to have that. We are gonna have for them to receive a gift card or something after this. And again, I am gonna be acknowledging them in all my work. And hopefully, if I'm able to, I will be able to have a picture of my participants with me, just so I can share that. But I don't just want to use them and leave them behind, but they're going to be part of this whole thing. And again, I'm using my voice to help them share their stories. It's not just for me, but it's setting those steps for them to come behind me.
I appreciate the inclusion of your participants being a part of the study. I'm curious, going through your university board for internal review board, how much they're going to be comfortable with the pictures being on there. But that's a good point. I've never actually thought of that. I've been on those committees before. That's a good point of how do you make sure people are included in a study, but they're also the participants in a way that gives them that, the empowerment of being a part of it, but they weren't the research. I don't know. Now you give me something else to think about. I didn't even get to the question. I got two questions for the price of one poster.
So right now I do a PowerPoint presentation, As long as I have my cousin's approval of using their pictures, I'm able to. As long as I think I did talk to my mentor about them having to sign like a form, and it's something that I think I will be putting in my IRB as well, is that they have to sign a form to allow for photos and all that stuff.
Sure, that's good, yeah. Well, I'm really curious to see how this all comes out. Hopefully it won't take too long to find your sample pool, be able to talk with them, and get to see a summary of some of the things that you learn. Adziri, thank you so much for taking the time. I appreciate it.
Yeah, thank you so much.
Of course. Oh, really great. I am curious. I hope you get results and either can come back, do another poster, or get a publication out on this. That would be, it's so needed to hear those voices and to know, like, what are some steps we're totally missing. I mean, I can guess, but who cares what I think? I'm not a high school new adulthood individual who's going through any transition right now. So.
Thank you.
Thank you very much. Nice to meet you. All right, we're talking with M. Burke about feasibility of adaptive gaming, a solution to gaming accessibility. And before you start talking about your poster, I got to say that no one's going to be able to see this because they're just listening, but a lot of the technology you brought here is a far cry from, I remember when I was a kid, we had Nintendo Power, and there was a letter someone sent in about I think it was like a brother who had some sort of accident and they couldn't use their arms anymore, and they had to play using this big Nintendo Advantage commercially available controller with their feet. And they were able to play video games with this. But it's nice to know that you're not just expecting people to use their feet with like big old 8-bit gaming consoles. This is much more complicated, it looks like.
No, yeah, and I really think whoever designed that had to be an OT. That's right up my alley. And as a future OT, as an OT student here, that was my whole thing. Like, I wanted to bridge that gap between people being able to play and not being able to play. Video gaming is a #1 leisure activity for a lot of people. It's also a very big social connection. We learned, especially during COVID, unfortunately, that building those relationships virtually is very important to us. And also people with autism and other things like that, like building those relationships virtually is a lot easier than that face-to-face contact. And gaming for all people is important. And then whenever you throw in, especially physical disabilities, it can make it a lot harder. So whenever consoles started developing and getting bigger, they realized that video gaming should be for everybody. So consoles started developing their own accessible controllers. PlayStation has the PlayStation Access, and Nintendo has their own, so does Xbox. And then through our OT program, we also 3D print a lot of things, different switches, different joysticks, touchpads, things like that, and different buttons as well. We wanted to provide this program education and just different information overall to the Mizzou students through the Gaming Lounge. The Gaming Lounge is already existing. We wanted to come in and help people, find whatever they can to try to make their video game experience more accessible, enjoyment higher, and we wanted to see if their mental health would improve through that as well. Whenever we came in, unfortunately, we had no participants through our open office hours. We were very well marketed and we advertised ourselves very well. We had different articles written about us. We sent out very many emails and included posts around campus and in the Disability Lounge and the center. We kind of saw that it could be intimidating. You have a group of peers asking if you want our help. Walking into that room could be a little intimidating, and also if you're of college age and you were born with a disability, you might already have a way of doing things that might work for you, and you might already be aware of these options. One thing that we could do in the future is maybe go into pediatrics. Think about, early intervention is the best intervention for most things. So if we could, find younger kids who wanted these options. We have a pretty awesome program called Pascal's Pals. They provide baskets and things for kiddos, and that could be a good chance to provide that option of, hey, here's an accessible controller as well. There's also different funding programs and grants out there that could provide things. But also, like post-acute, somebody has a life-altering thing happen to them, they still want to get back to gaming. Let's do this. But in the future, I would love to hold clinics and educations and teachings for other people in the program or like in the OT world, and just spread the knowledge as much as I can, because I think video gaming is so important.
It's a lot of fun. I don't get to do as much, like, I've had to move more towards board games as I get older.
Right.
But so I love, the being able to play video games. It's nice to see that there's still a room for video games.
Right.
I think most of the games that are just like the touch games, they're bad games. They're not well designed by people whose job it is to like make good games. So making sure that it's accessible. Because I
Yeah.
think the nice thing about an iPad game is as long as you mash the screen, however you're able to mash the screen, you're going to play the game.
Right.
The more complex games, you might need a more complex controller. Now, I know in OT that some of the kind of the technologies used are meant to sort of like strengthen or to make it easier to use, more of kind of what we'd expect is sort of like the standard controller. But with these controllers, these are meant to be, you can just use it, just use the controller. This is for you. You use it as long as it's the controller that works for you, correct?
Yeah, 100%. And that's the cool part of like, you can get the controller, anybody can. The fact of where we come in as OTs is the ergonomics of helping you bridge gaps between like where you want to be and where you are now. So you can get this controller straight out of the box, you can use it, but that doesn't mean that your setup is going to be as effective as it could be. And that's where we want to help. We could get a whole setup with different switches, the positioning of them. Let's say you, like your example, if you didn't have any arms, there are things, there's one called a sip and puff. It looks like a straw, blowing in, sucking in, rolling out, sucking in, sorry. It changes different controls. You can also get switches around your head to tilt left or right, and foot pedals, things like that. One, knowing that these things exist is hard.
Yeah.
We get trained about them, but also like finding all of these things, I had to dive deeper than just our regular OT curriculum.
Yeah.
But also like knowing what your potential can be and knowing like your limitations are two very different things.
Sure.
So going a step beyond of like, this is out of the box, but I don't really know what to do with it past that. We want to make sure that everybody has that information and you can be the best gamer with your setup that you can be. And also there's a lot of things, console settings that people like don't know exist. Like most consoles have accessibility settings that are like deep in there, which it kind of feels a little tricky that it's so hard to find the accessibility settings.
Weirdly enough, I feel like recent game, what was the last like complicated game I played? PS5. I played the Alan Wake remake, which is an old game, but it's not that old, I guess. And the Last of Us remake, I played that one. And it was like, look at all these accessibility settings. And it was almost overwhelming. It was like, congratulations, you really are thinking about every possible setting I could want. There are too many settings, though I don't know if anyone's going to be able to, even if they need the setting, if they don't see the one they want, it's like it's too much for everybody. Even the people who probably are like, hooray, more settings, I needed these.
Like, what do I do with it?
Yeah, I don't even know what some of them mean. Like, I don't even know if the language is really like, I mean, maybe it is, because they're not necessarily all going to be for me as the audience, but it's just some of them I don't think, or like I've seen the term that would be used by OTs, but that's not the term they're using there. Is it the same thing? Is it something different? How does it change my experience? Do I have to play the game for 20 minutes to be like, oh, I hate this, and turn, like that's a lot of extra work that you're asking people to do for settings that the goal is to be, we've made this game so much like easier for you to play or more accessible for you to play.
And that's so hard too, is like we don't want people to buy these options. And we don't want you to spend hours trying to see if it works for you. Like, we want you to, like, we want to find something that works for you before we send you out in the world and you spend hundreds of dollars on things that you don't know works. And you don't waste your time to be like, okay, I just played half the game, hated it, I'm just going to stop playing it. And, like, some of the adaptability options are you skip parts of the games or, like, you only get, like a cutscene for 30 minutes because it deemed that you couldn't play it. Like, we don't want that to happen. So whenever we, deem that something could be useful, we want to test that. And that's the cool thing about, like, if we are part of that service, like, we don't just, send you out blindly. If we can figure out things that could work for you, test them, and then be like, oh, actually, your satisfaction went up, and the effectiveness of your gaming capabilities also went up. That sounds like a good idea. Let's stick with that. Like, we want to make sure that our reasoning is sound, and then the actual outcome as well.
I love your idea of starting, with younger children, maybe as part of like check-ins. That might be a good place. Is like, oh, my son or daughter, they want to go play games, or they're not. They feel left out because this is part of their diet. Oh, I know someone who can come in and like do a quick assessment or find that. That would just be so nice. I mean, with unlimited money, I'm sure we'll be able to provide this service forever. But that's so important. Like, what a key, easy, I don't want to say easy, but video games as an easy social lubricant
Yes.
for children to get together.
Yeah,
and
especially
then
today's age.
Right? Oh. Okay, well, I can't wait to kind of keep seeing this line. I love the idea of more adaptive gaming. I love the idea of bringing more people into a hobby. It's a great hobby. And I promise no hard questions. I'm going to ask you one, though. What's the best game that's out right now?
Oh my gosh.
Yeah, I told you. It's going to be hard.
Well, I can tell you my favorite game of all time.
Okay.
Hands down is Skyrim.
Oh, okay,
Elder
Skyrim.
Scrolls, OG Skyrim.
Mm-hmm.
The best game out right now recently. I'm really excited for Skate.
Oh,
new
the skateboarding game. Okay,
yeah. The new
yeah.
Skate game that comes out. I think it's free to play like this 26th or something.
Okay.
16th. So there you go. That's
All right, I'm an old school Tony Hawk person,
this is different. Yeah, I don't think it's gonna beat Skate 3. But
okay, I have heard that one is the one to play.
That's the one.
I might give the demo a try.
Yeah,
All
looking
right.
forward to it.
All right, thanks, Sam. I appreciate
Thank you
it.
so much.
All right, so I'm speaking to Nanan Naraini about functional connectivity and volume of the amygdala as predictors of the response to propranolol. Now that's a hard one, for anxiety and autism. So it's a pilot study. And I have a consulting psychiatrist I work with a lot in my job, and she's a big fan of the amygdala. I hear it all the time. I know everyone's a big fan of their amygdala to some extent. So I'm very interested to sort of see what your pilot study sort of set out to do regarding it and its function in sort of the anxious response.
Okay, so we know what autism is, so I don't think I need to explain it again. And the interesting thing about autism is happens 1 in 36 children in the United States, which is a big deal for American government, right?
Mm-hmm.
And interestingly, also anxiety occurs at higher rates in autism populations compared to general populations and other neurodevelopmental disorders. So anxiety is a very big deal in autism research, right? And one of the part of the brain that kind of like responsible for anxiety is called amygdala. Before that, I would like to have some quizzes.
Oh no!
So can you please guess where's the locations of amygdala?
Oh, gee, is it there? Am I close?
Yeah, it's here. You're
It's
close.
right there. Okay, I was close.
Exactly.
It's been a while since I've done my Neuro 1 class.
You're fine, but so you know, right? So there's the location of amygdala. So amygdala is actually part of the brain that's responsible for fear and emotions, which is of course related to anxiety. And we thought that because it's related to anxiety, maybe we could use amygdala as biomarkers of autism. So what we did was we did some clinical trials with propranolol to the treatment of anxiety, and we did propranolol because it has shown a potential to alleviate anxiety because it's attenuating the sympathetic response that promoting calm. What we had was 16 young adults aged 16 to 23, and we did clinical global impressions did by our clinicians. 7 is very much worse and 1 is very improved. And we measured their amygdalar functional connectivity. What we want to do is we want to know which individuals are the best responders. We want to know the differences between the responders and non-responders.
Okay.
But what is responders? So the responders is the one who have anxiety measurements, CGI anxiety, score 1 or 2, very much improved or much improved after 12 weeks using propranolol.
Okay, so they're on the drug and
They're
they
on
are
the drug.
reporting, you know what,
Exactly.
feeling much better. Okay.
Yes, and all of this was done by clinicians, not me, because I'm not clinician, I'm a researcher. And the non-responders have scored 3 to 7, which is minimal improved to very much worse. What we found was, interestingly, compared to our hypothesis, the one who responds best for this drug is the one who has weaker connectivity between amygdala and occipital lobe.
So they responded better even though they had weaker connectivity?
Exactly.
Okay.
Yes. It's contrary to our hypothesis because we thought maybe the one who had greater connectivity will be the best responders, right?
Because I'm under the impression that the amygdala is like the super most powerful, anxious,
Exactly.
semi-organ in the body. So
Yeah.
I am a little surprised that the
Same
results
with me.
were that.
Yes. So, and then I found this interesting article. They showed that there is another pathway for emotions that goes through the occipital lobe, which is called visual sensory emotional. So this pathway is directly goes to central limbic nuclei with this amygdala. So it's kind of like interesting. Maybe in the future we can take a look at amygdala and occipital lobe instead of like just focus on amygdala because it's process all of the emotions. So our future study, hopefully we can have like bigger data, any more participants, and we could look at occipital lobe in addition to amygdala.
Okay, so what you were looking for didn't quite give you the results you were expecting. So there's more updates to the next pilot.
Exactly,
it sounds like.
but one thing that we know for sure that we can use amygdala for the biomarkers, even though we still need more people to participate in our study and more brain regions to be observed.
Gotcha. Okay, so there's room to grow on everything so
yep.
far. Okay, but you know what? Sometimes getting weird responses, getting weird results. That's part of the process. That's why it's science and not just made up business gobbledygook, I suppose.
You are definitely right.
Oh,
My brain.
your brain.
I'm good as a fake brain.
Good thing too. Well, Nanan, thank you so much for your time. I really appreciate it.
Thank you so much. Nice to see you.
So I'm talking with Sofia Marchetti about bridging bench to bedside, which I appreciate in a poster, a title with a colon, and then you tell me what's in the translational approaches to rare neurogenetic neurodevelopmental disorders. Okay,
Correct.
okay. There's a lot of graphics on here,
There
so please, Sophia, walk me through this.
Yes, I'd love to walk you through it. So I work on a really amazing team that studies rare neurogenetic and neurodevelopmental disorders. So what we have done is we've created a translational pipeline. So it goes from the identification of the rare neurogenetic or neurodevelopmental disorder, enrolls participants into a natural history study, and then builds out models. So mouse models, iPSCs, fly models, and then molecular studies to hopefully find a treatment option for these patients. As we know, rare diseases are not studied as it's becoming a lot more popular now, which is really exciting, but hopefully this pipeline can be built upon and put in these rare diseases to find treatment options.
Okay, so could you give me an example? Because some of those terms I'm a little more familiar with. Some of them I'm like digging deep to undergrad classes on biology. Like what would it kind of look like in practice? So hey, I've got a rare disorder. It's in a book. Someone found it in a dusty old tome, but we don't know what to do with it. How would it look?
Of course. So that's a great question. So we're starting out our transitional pipeline with SYT1 Baker-Gordon syndrome. Okay. So this was a newly discovered disorder in 2019, 2018.
Oh, okay.
So very new. We are building out a natural history study. So we enroll patients into that, and from there they complete clinically meaningful assessments and finding those endpoints for therapeutic treatment. Then using that information, we can build these mouse models, the fly models, and the iPSCs, so the stem cells, and look for those, see if they correlate with the natural history study, and then plug those therapeutic treatments into that.
Okay.
If that makes sense.
A little bit. So the human iPSC model, that's like computer modeling or that is modeled
So that is a skin biopsy, and then we build the stem cells out in a dish.
Ah, all right. Okay,
Yes,
so
yeah.
it's
So
all
it's a model
actual,
of the disease.
like
Yes.
wet work stuff. Like
Yes.
you're looking at something. All right.
Yes, yeah.
Okay.
So all the bench to beds.
Oh my good. Okay, so this is something where there's a lot of both the assessments and then there's a lot of like direct lab work looking at cells and
it's very much a translational model.
Okay.
So that's what makes it different and really cool. I know there's a lot of translational things going on, but it really highlights a lot of important steps to go through to finding treatment options.
Now, I understand how science works. It's a process. It's iterative. We build on things. Sometimes there's funding. Sometimes there's not. Fits and starts, technology. If I were just hearing, hey, there's this translational approach I heard about, and if I did not have a background in science, I were not at a conference where people are talking about medical models, what does any of this matter? Like, what's the long-term plan of once this is perfected? What does it mean for just a person, just for anyone?
For anyone, it would
with a rare condition, certainly.
For a person with a rare genetic disorder, it really would mean a lot to them because it would give them the security or not security, but knowledge of knowing that someone's trying to find a treatment option for them. So being able to go through this and connect with people who also have the same disorder as you, because these are rare genetic disorders. So finding those families and being able to connect with other people who have that same thing, that is so important for these people and for these patients. So being able to expand these studies and connect them is really the broader implications.
And I appreciate, I didn't even think about the idea of patient advocacy or a patient socialization around these issues.
Yeah.
I usually see medical models and I'm like, you're going to find a cure, you're going to find the textbook example. So that's,
right.
Wow, was that always part of the model, or that sort of was something that naturally occurred during the initial pilots? Or?
Yeah, that was something that we were like, oh, that'd be really cool to incorporate, but being able to work with, so we work with the Baker-Gordon Syndrome Foundation, and being able to say to patients, oh, you can go to them and connect with them. It's really meaningful for the parents, caregivers, and patients to be able to do that.
Yeah, I would guess it must be very frustrating if you are dealing with the ramifications of having a rare genetic disorder.
Yes.
To have no one's ever heard of it. That's
right.
not. Okay, that might be good for you, doctor, telling me this, or you're going to publish something, but not for me, the
right.
person who's dealing with whatever the complications this may be. So having that collaboration, different groups, excellent.
Yeah.
All right, well, I don't know if I understand all the I certainly don't understand all the nitty-gritty of most of the models in here, but I do appreciate your explaining the overall pipeline, the plan, the goals.
Yeah.
So thank you so much, Sophia.
Of course, yeah, it was nice to meet you.
Nice to meet you.